Welcome to the deep dive. We're going to jump straight into a really specific document today. Our focus is an actual boots-on-the-ground admission protocol for patients arriving at a hospital with a diagnosis of deep vein thrombosis DVT.
That's right. And the material we're really dissecting here, it's drawn from excerpts of an admission protocol, deep vein thrombosis. It's a document attributed to Dr. Gregory Weir.
Okay.
And we can see here he's a practicing vascular surgeon. Got his MBCHB, MMed, a certificate in vascular surgery, and IIWCC credentials listed. So that suggests, a very specific, specialized clinical setting where this protocol is actually being used.
Right. And for you, the specialist clinician listening in, our goal isn't just to, read this protocol out loud. It's really about taking this very structured step-by-step guide and, while peeling back the layers, we want to extract not just what it says, but the clinical thinking behind it, the priorities, the sort of hidden whys, and all those specific details that make this particular approach work.
Exactly. It's about understanding the underlying principles, the practical workflow, really from a specialist's point of view. Think of it like analyzing the clinical algorithm that's kind of embedded within this document.
Okay.
Yeah, this isn't your standard textbook chapter on DVT management. It's more like a practical blueprint for patient care right at admission in one specific practice. Understanding its structure, its explicit instructions, it gives us real insight into how one expert team takes those general DVT principles and turns them into something concrete, something actionable in their workflow.
Okay, so let's unpack this then. Starting right at the very beginning of their process, Section 1, patient identity. The protocol lists this as the absolute first step, like right when the patient arrives in the ward or unit.
Yeah.
Now, for any clinician, conferring identity is obviously foundational. But seeing it spelled out, number one, in a specialized DVT protocol, well, that tells you something straight away, doesn't it?
It really does. It highlights that even in, specialized high acuity care, the most basic patient safety steps are still absolute paramount. And they're reinforced at every single transition point.
Right.
The protocol is very specific about how to confirm identity, too. It mentions using multiple cross-checks, the hospital sticker, asking the patient directly verbal confirmation, and importantly, confirming with family members if they're there.
That multi-modal approach.
Exactly. It's not just about ticking a box. It's a critical safeguard.
But why make this the absolute first thing? Before even, say, initial vital signs or getting the patient comfortable?
Well, because patient misidentification, it's a surprisingly persistent problem in healthcare, and the consequences can be catastrophic.
Yeah.
Imagine giving the wrong medication, especially potent anticoagulants, to the wrong DVT patient or doing the wrong procedure. It's devastating. So putting identity verification right at the very top, number one, and requiring these redundant checks, it really embeds a safety culture right from the start. It forces the team to just pause, take a breath, and confirm they absolutely have the right person before they start doing anything clinical based on that DVT diagnosis. It seems simple, maybe, but its placement just underscores how fundamentally important it is for preventing medical errors. And those errors are particularly risky when you're talking about interventions like therapeutic anticoagulation.
Makes sense. And alongside that really critical safety step, the protocol also mentions adding a human touch.
Yeah.
Welcoming the patient and family, assuring them about the care.
Yeah, that detail's interesting, isn't it? It kind of injects that empathetic piece into what's otherwise a very clinical, very procedural document.
Right.
It's a reminder to the staff that, alongside all the critical clinical tasks, building that rapport, providing reassurance to the patient and their family during what's probably a really stressful time, that's also part of the whole process. It sets a tone, doesn't it? A tone of care and competence.
Okay, so identity confirmed, patient welcomed. The protocol then moves pretty quickly into Section 2, blood tests, and it specifically names Lancet Laboratory.
That implies, doesn't it, that there's a designated lab service that's really integral to this whole workflow.
Yeah, seems like it.
And the list of tests they require gives us the first sort of clinical data points this protocol really prioritizes right at admission. First up, they list UKA.
UK urea, creatinine, and electrolytes.
Exactly.
Now, for a specialist clinician, the immediate relevance of urea and creatinine in a DVT patient, especially thinking about treatment, it points straight to kidney function, right?
Absolutely. Straight away, you're thinking about drug metabolism and excretion. Why? Because, well, a lot of the medications we use for DVT, particularly the anticoagulants, they're either processed by the liver and then cleared by the kidneys, or sometimes just cleared mainly by the kidneys unchanged.
Okay.
Think about the low molecular weight heparins like Enoxaparin and Klexane is the brand name here. They're largely cleared renally.
Right.
And some of the direct oral anticoagulants, the DOACs, they also rely pretty heavily on the kidneys for excretion. So if a patient's kidney function is impaired, these drugs can potentially build up.
To toxic levels.
Well, to super therapeutic levels, certainly. And that significantly increases the risk of bleeding. So knowing that baseline renal function through the urea and creatinine, it's absolutely essential for picking the right drug and, crucially, adjusting the dose based on the patient's estimated GFR, their glomerular filtration rate.
And the electrolytes.
Electrolytes are, generally important for any hospitalized patient. Assessing their overall status, fluid balance, maybe looking for potential issues like refeeding syndrome or effects from fluid shifts, perhaps less directly tied to the DVT itself compared to kidney function and the anticoagulant choice, but still important baseline info.
Okay. Next on the list is hematocrit. A pretty basic measure, but what's its specific value here, do you think?
Hematocrit, yeah. It's the percentage of red blood cells in the total blood volume. Gives you a quick snapshot of the patient's red cell mass. It can flag up things like anemia or maybe significant dehydration or hemoconcentration. In the DVT context, with anticoagulant therapy coming, the baseline hematocrit matters for a few reasons. Firstly, if the patient's already anemic, even a small bleed caused by the anticoagulation could be more clinically significant.
Okay.
Secondly, a really high hematocrit polycythemia, that's actually a risk factor for thrombosis itself, so it could offer some diagnostic clues. And thirdly, if there's a bleeding complication later on, tracking sequential hematocrit levels is absolutely crucial for monitoring how much blood is being lost.
Got it. Then myoglobin is listed. Now this one, as I mentioned earlier, feels maybe a bit less standard for a routine DVT admission panel compared to, say, getting a D-dimer or a baseline coagulation profile.
Yeah, that's a really keen observation. A myoglobin, well, it's primarily a marker of muscle injury, isn't it? Rhabdomyolysis.
Right.
So seeing it included here in this specific DVT admission protocol, it does stand out. It's definitely not universally standard. Why might it be in there?
Yeah. What's the thinking?
Well, we can only really speculate based on the text, I suppose. It could reflect the kind of patient population that Dr. Weir's practice tends to see. Perhaps patients with trauma, maybe crush injuries, or other conditions that might predispose them to both DVT and muscle damage.
Ah, okay. So a specific patient mix, perhaps.
Potentially. Or it could just be part of, like, a standardized comprehensive metabolic panel or admission panel that their hospital system uses routinely, regardless of the main diagnosis.
Like a bundled set of tests, maybe.
Exactly. Without more context from the source, it's hard to be certain. But it does highlight how specific practice protocols can sometimes include elements that deviate a bit from the broadest standard guidelines, maybe based on local factors or that patient mix. It certainly makes you, as a specialist clinician, pause and ask, okay, why myoglobin here?
Yeah, interesting. And then critically, for patients who might be going on to Warfarin, INR is listed.
International Normalized Ratio, yes.
Yeah.
The standard measure for monitoring the effect of warfarin, that's the vitamin K antagonist that messes with the synthesis of clotting factors in the liver. Right.
And INR is absolutely essential because warfarin's effect, well, it varies hugely from person to person. The protocol mandates, it says, must be done daily INR tests if warfarin has been prescribed.
Daily testing. That sounds pretty intensive. What's the rationale for that frequency, especially rated admission?
Well, the reason for daily INR testing, particularly during that initiation phase of warfarin therapy, it's really twofold. You're looking at efficacy and safety.
Okay.
Warfarin has a pretty slow onset of action. It takes several days for its full anticoagulant effect to kick in as the body clears out the clotting factors that were already there. So during this ramp-up period, the INR needs really frequent checking, often daily, just to make sure the patient is heading towards and then actually gets into the therapeutic target range.
Which for DVT is usually...
Typically an INR between 2.0 and 3.0. But at the same time, warfarin's dose is incredibly sensitive to all sorts of things. Diet, especially vitamin K intake, loads of drug interactions, illness, even genetic variations.
Right. So daily testing lets clinicians titrate that dose really precisely. You want to avoid levels that are too low subtherapeutic because that won't prevent the clot from extending or embolizing. And crucially, you want to avoid dangerously high levels that lead to a major bleeding risk. So this daily monitoring, it's really a cornerstone of safe and effective warfarin loading.
Okay, so baseline labs are drawn. Section 3 then moves on to other investigations. And this section have a very specific, almost restrictive feel to it regarding imaging.
Yes, it lists several advanced imaging options: chest X-ray, CXR, duplex Doppler ultrasound, magnetic resonance angiography, MRA, computed tomography angiography, CTA, and also CT pulmonary angiography, CTPA.
Quite a list.
It is. But the absolutely crucial directive here is that these investigations should only be performed at the specific request of Dr. Weir.
That's a very clear centralization of decision-making, isn't it?
Yeah.
Especially for potentially expensive or complex tests. What does that tell you about how this protocol is designed?
It strongly suggests that they prefer a standardized initial clinical assessment and management approach, and that advanced imaging is really reserved for specific clinical questions or maybe suspected complications that are identified directly by the treating physician.
Okay.
For instance, a chest X-ray might be needed if the patient has respiratory symptoms, or maybe just for a big line before a procedure. A duplex Doppler, well, that's key for diagnosing DVT or maybe checking its extent. But perhaps this protocol assumes the diagnosis leading to admission was already solid.
Or maybe Dr. Weir does his own assessment first?
Possibly. Or performs an initial clinical assessment before deciding if more imaging is needed in the hospital. MRA or CTA, they might be for looking at associated arterial disease or perhaps complex venous anatomy. And CT, pulmonary angiography, CTPA, that's the gold standard for diagnosing pulmonary embolism, a big, scary complication of DVT.
Right.
So, by restricting these tests to a specific request, the protocol seems to be aiming to ensure they're used really judiciously, only for clear indications. It likely aligns with the practice's own diagnostic algorithms and maybe resource management strategies, too. It stops indiscriminate ordering and makes sure tests were done only when they're genuinely going to add value to managing the patient based on the physician's direct assessment.
It also implies that not every single DVT admission automatically triggers, say, repeat imaging or a massive workup beyond those initial bloods in the clinical exam.
Yeah.
Not unless the physician sees a specific need, a clinical trigger.
Precisely. It puts the onus squarely back on the physician's clinical judgment to figure out when these extra investigations are actually warranted. It's not just an automated part of the admission pathway.
All right, let's get into the real core of treatment. Medication, Section 4. This looks quite dense, starting with Klexane.
Yes, Klexane, which is enoxaparin, low molecular weight heparin, or LMWH. These are really cornerstone drugs for that initial DVT management. The protocol just says, if it's prescribed, administer it according to Dr. Weir's prescription.
And it gives a very specific example of how they calculate the dose.
It does. It uses the common therapeutic dosing for DVT, 1 milligram per kilogram, twice daily noted as BD in the text, but meaning twice daily.
Okay.
And it gives a really straightforward example calculation. For a 100-kilogram patient, the dose is 100 milligrams twice daily. This is pretty standard therapeutic LMWH dosing, usually given subcutaneously. And the example just reinforces that weight-based nature of the dose, which is absolutely critical for both efficacy and safety. You need to achieve adequate anti-factor Xi levels with that weight-based dosing for LMWH to be properly therapeutic.
Then we circle back to Warfarin again. And this section expands a bit on how it's managed once the INR results are in.
Correct. The protocol states that once those INR results are available, Dr. Weir must be contacted so he can decide the appropriate dose of warfarin. This just emphasizes, again, the physician's central role in titrating that warfarin therapy, using the lab result, aiming for that therapeutic target INR again, usually 2.0 to 3.0 for DVT.
And here's that really crucial transition point we sort of touched on earlier.
Yes, the protocol states it explicitly. Critical. If the INR is more than 2.0, Klexane must be stopped. This is absolutely fundamental when you're bridging from a fast-acting anticoagulant like Klexane to the slower-acting warfarin.
Okay.
Once the INR shows that the warfarin has reached a therapeutic level conventionally, that's an INR greater than 2.0 than the Klexane, which provided that initial immediate anticoagulation, well, it's just not needed anymore. It should be stopped.
I guess continuing both would be dangerous.
Exactly. Continuing both significantly ramps up the risk of bleeding without really providing substantial extra benefit for preventing clots at that point. This is a key safety check: avoid excessive anticoagulation. It's also, frankly, a common point where errors can happen in clinical practice if it's not followed really strictly.
And Lancet Laboratories seems to have this expanded role again for warfarin patients.
Yes, they're actually tasked with counseling the patient about the long-term use of warfarin. And this is such a vital piece of patient education because warfarin, as we know, it's a complex medication to manage long-term.
Right.
That counseling needs to cover the importance of taking it consistently, the impact of diet, especially vitamin K on INR levels, potential interactions with other drugs and even supplements, the absolute need for regular INR monitoring, and how to recognize signs and symptoms of bleeding. Good patient education is just critical for warfarin safety and making sure patients stick with it properly.
And they also handle the logistics of follow-up, too.
They do. The protocol directs that Lancet Laboratories should arrange follow-up visits at a branch near the patient's home for when the patient gets discharged. This really highlights an integrated model of care, doesn't it? Where the lab itself is responsible for facilitating that ongoing outpatient management specifically, the crucial regular INR tests, and the dosage adjustments based on those results. That's the standard of care for patients maintained on warfarin.
What about the direct oral anticoagulants? Xarelto is listed here.
Yes, Xarelto, which is rivaroxaban, one of the DOACs. The instruction here is much simpler compared to warfarin. It just says, please give the dose prescribed.
Okay.
And it gives an example. Xarelto, 15 milligrams twice daily. That 15 milligrams twice daily dose, that's the standard initial treatment dose for rivaroxaban in acute DVT, typically given for the first 3 weeks before stepping down to a maintenance dose, which is usually 20 milligrams once daily.
And unlike warfarin.
Exactly. Unlike warfarin, DOACs like rivaroxaban don't need that routine coagulation monitoring like INR testing, which for many patients simplifies outpatient management considerably.
And similar to the Klexane-warfarin interaction, there's a really critical instruction about using Klexane and Xarelto together.
Yes, another critical point flagged in the protocol. Do not administer Klexane to patients on Xarelto. This is an absolute no-go.
Why is that?
Well, they're both potent anticoagulants. They work differently. Sure, Klexane or enoxaparin targets factors A mainly through antithrombin, while rivaroxaban directly inhibits factors A. But giving therapeutic doses of both at the same time would just exponentially increase the patient's risk of severe, potentially fatal bleeding.
Okay.
And without providing significant added clinical benefit for preventing thrombosis compared to just using either drug properly on its own. So if rivaroxaban is the chosen therapy, Klexane is simply not given concurrently, period.
The protocol also takes time to address antiplatelet drugs.
It does, yeah. Mentioning examples like Ecotrin, which is aspirin or clopidogrel, and the general rule is stated very clearly. They should not be used with Klexane, Xarelto, and warfarin.
And the reason for that general rule?
It really just boils down to additive bleeding risk.
Yeah.
Anticoagulants, they work on the coagulation cascade, the clotting factors. Antiplatelet drugs, they inhibit platelet function, how platelets stick together to form that initial plug.
Right.
So using both classes of drugs together, sometimes people call it dual pathway inhibition, it significantly impairs the body's ability to form clots, even minor ones needed for vessel repair. This dramatically increases the risk of major hemorrhage, especially things like gastrointestinal bleeding or bleeding after any kind of trauma.
But there's an important exception noted in the protocol.
Yes, it does allow for antiplatelet use, but only unless specifically requested and prescribed by Dr. Weir.
Okay, so physician override again.
Exactly. It acknowledges that some patients who have a DVT might also have other conditions that genuinely do require antiplatelet therapy. Things like a recent heart attack, maybe coronary stenting, or certain types of arterial disease. In those cases, the decision to combine these therapies has to be weighed up really carefully, balancing that increased bleeding risk against the thrombotic risk of stopping the antiplatelet. And it requires that explicit physician override and prescription. It highlights that even within what seems like a rigid protocol, there's still a mechanism built in for managing complex patients under direct physician guidance.
Pain management is also a key part of this medication section.
And rightly so. Pain is a very common, often really significant symptom of acute DVT. It's caused by the vein stretching, inflammation, and that swelling, the edema. The protocol instructs staff to administer analgesia according to the prescription and gives a range of examples.
What kind of options are listed there?
Well, they give examples like Tramacet, 2 tablets 3 times daily. That's TDS, 3 times daily. Tramacet is a combination of tramadol, which is an opioid analgesic, and paracetamol, or acetaminophen. They also list perfalgan 1 gram intravenously 3 times daily, that's IVI, intravenously. Perfalgan is the IV form of paracetamol, which is useful if patients can't take oral meds or maybe need faster pain relief.
Right.
And they also mention Targinact 105 milligrams twice daily BD, twice daily. That's a combination opioid analgesic containing oxycodone and naloxone. It provides stronger pain relief, potentially for severe DVT pain, and the naloxone component is included there to try and mitigate opioid-induced constipation.
So quite a range of options.
Yeah, it suggests a tailored approach to pain relief depending on how severe it is, and the patient's overall status, includes both oral and intravenous routes.
And just like with the anticoagulants, there's another critical contraindication listed specifically for pain relief.
Yes, another one flagged as critical, a strong warning.
Oh.
NSAIDs, non-steroidal anti-inflammatory drugs, are not allowed. It's an absolute prohibition within this protocol.
And the rationale given connects right back to the anticoagulant use, doesn't it?
Exactly. The reason stated is due to interaction with anticoagulants and increased risk of hemorrhage and other complications. NSAIDs pose several risks when you combine them with anticoagulants.
Like what specifically?
Well, firstly, they independently increase the risk of gastrointestinal bleeding. They can damage the stomach lining, the mucosal barrier, and they inhibit chio-X1, which helps make protective prostaglandins in the stomach.
Sure.
Secondly, most NSAIDs also have an antiplatelet effect. They inhibit platelet function, usually weaker and often reversible compared to drugs like aspirin or clopidogrel, but it's still there. Combining that antiplatelet effect with systemic anticoagulation just significantly magnifies the overall bleeding risk. And furthermore, some NSAIDs can actually interfere with the metabolism of certain anticoagulants. It's less of a concern maybe with LMWH or the DOACs, but it's a known issue with warfarin for certain NSAIDs. So the protocol is crystal clear. Avoid NSAIDs entirely in these patients, minimize that bleeding risk. It's a really crucial safety point and a common clinical pearl, isn't it? Reach for paracetamol or opioids, not NSAIDs, in anticoagulated patients who have musculoskeletal or DVT-related pain.
Okay, we've worked through the initial steps and the really critical medication protocols. Section 5 then shifts the focus to broader patient management aspects.
Yeah, this section gets into those essential non-drug interventions and the monitoring side of things. It kicks off with limb elevation, another absolute fundamental of DVT care. The protocol states, critical, elevate the patient's affected limb at all times to reduce edema.
And why is limb elevation considered so critical in acute DVT? What's the physiology there?
Well, the basis is pretty simple, but it's effective. It's gravity. When a deep vein is blocked by a clot, the return of blood from the limb back towards the heart is impaired. Blood can pool, and that increases the hydrostatic pressure in the veins below the clot. That forces fluid out into the surrounding tissues, which causes the swelling, the edema, and often contributes significantly to the pain.
Okay.
So elevating the limb uses gravity to help drain that blood and lymphatic fluid from the affected leg or arm back towards the trunk. This lowers the venous pressure, reduces the swelling, and can really alleviate the patient's discomfort and pain quite effectively.
And the protocol actually specifies the positioning based on whether it's a leg or arm DVT.
It does. For a leg DVT, it directs that the patient should be placed in the Trendelenburg position. That's where the patient lies flat on their back, but the foot of the bed is raised, so their feet are elevated higher than their head.
Right, maximizing gravity.
Exactly. It maximizes that gravitational assistance for venous return from the legs. For an arm DVT, the instruction is simply that the arm should be elevated, which you can usually achieve quite easily with pillows. The core principle is the same, though. Get the affected limb up above the level of the heart.
An interesting inclusion here, I thought, was applying an oxygen mask routinely.
Yes, the protocol specifies applying a 40% oxygen mask at greater than 5 liters per minute. Now, routine oxygen therapy isn't usually standard for just uncomplicated DVT itself.
So what's the likely reasoning behind including this as a standard part of this admission protocol?
Well, it suggests a pretty proactive approach, doesn't it, to mitigating or maybe managing potential hypoxemia low oxygen levels. While oxygen doesn't treat the clot, putting it in here points towards maybe a high index of suspicion for, or perhaps just preparedness for, a pulmonary embolism, PE.
The major complication.
Right. PE is the most serious acute complication of DVT. Happens when a piece of that clot breaks off, travels to the lungs, and blocks pulmonary arteries. A significant PE can cause serious hypoxemia. So, providing supplemental oxygen right up front ensures adequate oxygenation, which is critical if the patient does develop shortness of breath or low oxygen levels because of a PE.
Okay.
It could also just be a standard admission order in this specific unit or maybe for this practice for patients with significant vascular issues generally, just to ensure adequate tissue oxygenation more broadly. But for you, as a specialist clinician seeing routine oxygen, it definitely prompts the thought. Are they anticipating a high rate of PE in their admitted DVT patients, or is this just part of a broader standing order set?
Makes you wonder. Monitoring vital signs is obviously standard for any hospitalized patient, but the protocol specifies a particular pattern for the frequency.
Yes, it lays out a kind of stepwise approach. Vital signs, so blood pressure, heart rate, respiratory rate, SpO2, oxygen saturation via pulse oximeter, and temperature should be assessed every 60 minutes for the first 6 hours after admission.
Okay, hourly for 6 hours.
Right. And then following that initial period, the monitoring frequency gets reduced to once every 6 hours.
What's the clinical thinking behind that initial, more intensive monitoring phase?
Well, those first few hours right after diagnosis, admission, and starting treatment, that's really the most dynamic period. Patients might experience rapid changes in their condition. They might be responding to the treatment, or they could potentially develop acute complications like a big PE or maybe hemodynamic instability. So more frequent vital sign monitoring during that critical early phase just allows the clinical team to pick up any signs of deterioration. Things like hypoxemia, tachycardia, low blood pressure, fever, much, much faster. And detecting those changes promptly allows for timely intervention. Once the patient seems stable through that initial treatment phase, then the frequency of monitoring can usually be safely reduced to a less intensive schedule.
There's another critical instruction here, related specifically to the affected limb.
Yes, the protocol strictly states, critical, do not apply a blood pressure cuff or do venipuncture on the affected limb.
Why is it so important to avoid those particular actions on the limb that actually has the DVT?
Well, think about applying a blood pressure cuff. You inflate it way above systolic pressure to stop arterial flow, then you slowly let it down. That puts significant external pressure on the whole limb, including right over the area where that thrombosed deep vein is. And venipuncture, well, that involves sticking a needle into a vein. Both actions could, theoretically at least, cause discomfort, pain, or, importantly, apply external pressure or trauma that might disrupt the clot or maybe damage the already inflamed vein wall.
Is the risk of dislodging the clot real with those?
The actual risk of dislodging a clot with these actions is probably debated and likely quite low with modern management approaches. But avoiding any unnecessary manipulation of an acutely thrombosed limb, which is often quite painful anyway, it's just a standard precautionary measure. And it definitely contributes to patient comfort. Plus, trying to get blood from a vein in a limb that has significant venous blockage due to a DVT, it's often technically really difficult and can be very painful for the patient.
Makes sense. And speaking of potentially life-threatening complications, the protocol has a very specific instruction regarding chest pains.
Yes, this one's also listed as critical. Inform Dr. Weir if the patient experiences chest pains, potential pulmonary embolism. This is just a fundamental red flag symptom in any patient with a DVT. Chest pain, especially if it's new or getting worse, in this context has to immediately raise suspicion for a pulmonary embolism, where part of that leg clot has traveled up to the pulmonary circulation. The protocol emphasizes immediate escalation by contacting the physician. That's to facilitate prompt assessment and investigation for PE, which is, of course, a medical emergency.
The protocol also mandates completing the clinical assessment properly.
Right. This involves gathering and documenting really crucial patient information, things like assessing and documenting any patient allergies maybe to iodine contrast or antibiotics. That's vital for preventing adverse reactions, especially if contrast imaging like a CTPA or MRA-CTA might be needed, or if antibiotics are considered for any reason.
Okay.
And assessing and documenting all current medications the patient is taking, especially any anticoagulants or antiplatelets they were already on when they came in. That's paramount. It helps the team understand the patient's baseline coagulation status and, critically, avoid potentially harmful drug interactions with the new DVT treatment they're about to start.
Evaluating circulation is also included here as part of that assessment.
Yes, the protocol details how this should be done. Palpating pulses, assessing Doppler flow, presumably arterial Doppler, and evaluating the color and temperature of the affected limb. This assessment gives critical information about the arterial circulation to the limb.
Why focus on arterial when the problem is venous?
Because while the DVT is blocking venous outflow, it's absolutely crucial to make sure there's still adequate arterial inflow. If you find reduced pulses or abnormal arterial Doppler signals, or the limb looks pale or feels cold, that could indicate the patient also has arterial disease happening at the same time, or maybe the venous congestion is so severe it's actually impacting arterial perfusion. And that would have really significant implications for management, especially when it comes to deciding whether or not to use compression, which we'll get to next.
Right, okay. And finally, under this patient management section, there are points about comfort and basic hygiene.
Yeah, these are standard nursing care points, but still important for overall patient care. Things like keeping the patient as still and comfortable as possible, asking them to remove any restrictive clothing like tight socks or trousers that could potentially impede circulation further, and then basic hygiene measures like showering with chlorhexidine soap or maybe a sponge bath if they can't shower. These all contribute to patient well-being, reduce potential discomfort in that affected limb, and help maintain skin integrity.
Okay, moving on to section 6, which covers patient activity. This section addresses that balance between rest and mobility, which is a topic where, well, clinical practice guidelines seem to have evolved quite a bit over the years regarding DVT.
They really have. Historically, strict bed rest was heavily emphasized, wasn't it? The fear was dislodging the clot. However, current evidence often leans towards early ambulation, usually combined with compression. This protocol seems to adopt a kind of blended approach. It starts with an initial period of restriction. It states, the patient should be restricted to bed rest in the first 12 hours after admission.
Okay, so a mandated 12-hour period of bed rest. What's the likely thinking behind that specific duration in this protocol before they start encouraging movement?
Well, that 12-hour window might be seen as an initial stabilization phase. It lets the patient settle in after admission, it ensures they've received their first dose of anticoagulation, like the Klexane, and it provides a kind of buffer period where the anticoagulant can start to work, potentially reducing the risk of the clot extending or embolizing before activity levels are increased.
Makes sense.
While the evidence doesn't universally mandate a specific period of bed rest anymore, this protocol integrates a sort of cautious initial approach before it transitions to more active management. It could also just align with practical workflow, allowing time for those initial assessments, labs, medication administration, before the focus shifts to encouraging activity.
And during that initial bed rest phase, are there restrictions on position beyond just lying flat?
Yes, the protocol clarifies that too. It says, the patient should avoid sitting upright and may sit at an angle of 45 degrees when eating or drinking.
Why avoid sitting fully upright?
Avoiding prolonged upright sitting is important because that puts the affected limb in a dependent position relative to gravity. That increases hydrostatic pressure in the veins and can potentially worsen the edema and the pain. Allowing a 45-degree angle seems like a compromise. It permits comfortable eating and drinking without forcing the limb into that fully dependent upright posture for long stretches.
Okay, and then after those first 12 hours are up?
Then the protocol shifts gear. It encourages ambulation. It states, patients should be encouraged to ambulate frequently, for example, short walks every 1-2 hours, and avoid prolonged sitting or standing still once compression is applied.
Ah, that's a really key link there. Ambulation is encouraged, but specifically once compression is applied. Why is compression so tightly linked to that shift towards mobility in this protocol?
Yeah, this is a critical point, and it really reflects current best practice thinking. Encouraging ambulation, walking, it leverages the calf muscle pump. When you walk, your calf muscles contract, and that compresses the deep veins, helping to propel blood upwards, improving venous return and reducing stasis.
Right.
However, walking without adequate external support in a limb where the venous system is blocked could potentially increase venous pressure and make swelling worse. So compression, whether it's bandages or hosiery, provides that external support that counteracts the effects of gravity when the patient is upright or walking.
Okay.
It supports the venous walls, reduces venous stasis, helps maintain blood flow velocity in the veins, and minimizes that increase in venous pressure that happens with ambulation. Therefore, combining ambulation with compression is generally considered beneficial. It helps reduce symptoms, improves venous hemodynamics, and potentially, importantly, reduces the risk of developing post-thrombotic syndrome in the long run. This protocol implements that combined strategy, but only after that initial resting phase.
Finally, under patient activity, there's a note about smoking.
Yes. Patients should be actively discouraged from smoking. This is such a vital piece of long-term risk factor modification, isn't it?
Absolutely.
Smoking is a major risk factor for pretty much all cardiovascular disease, including both arterial disease and venous thrombosis. It damages the endothelium, the lining of the blood vessels, it promotes inflammation, increases platelet stickiness, and generally contributes to a hypercoagulable state. While stopping smoking won't magically fix the acute DVT right now, it's absolutely crucial for preventing future thrombotic events and just improving overall vascular health down the line. Addressing smoking cessation has to be an important part of managing any patient with vascular disease.
Section 7 then focuses entirely on compression, really elaborating on how it's applied and what type is used.
Yes, and it kicks off by reiterating that prerequisite we touched on earlier when discussing limb assessment. Compression will only be requested by Dr. Weir if the patient's arterial circulation is adequate.
And just as a reminder, why is checking that arterial circulation so critical before slapping on compression?
This is a crucial safety check. You absolutely have to avoid causing harm. Compression applies external pressure to the limb, right? The goal is to support venous return. But if the patient has significant underlying peripheral arterial disease where the arterial blood flow into the limb is already compromised, adding external compression can restrict that reduced flow even further.
Which could lead to?
Ischemia. Not enough blood supply getting to the tissues. That could cause severe pain, tissue damage, ulcers, or in the worst case scenario, even limb loss. So confirming adequate arterial inflow by checking pulses, maybe assessing arterial Doppler signals, looking at the limb's color and temperature, it's an absolutely non-negotiable step before you apply compression to an affected limb.
Got it. The protocol also refers to a specific technique for applying the initial compression bandages.
It does. It instructs personnel to familiarize themselves with the African bandage technique. And it even mentions there's a QR code, presumably linking to instructions or a video. While the document itself doesn't detail the steps of this technique, naming it specifically emphasizes that they use a particular, perhaps layered or multi-component standardized method for applying compression bandages in this practice. That standardization aims to ensure they get consistent pressure application, which is important for both effectiveness and patient comfort.
So bandages are used initially, presumably while the swelling is greatest, but there's a planned transition later on.
Correct. The protocol states that when the edema, the swelling of the affected limb has subsided sufficiently, Dr. Weir will then request that an orthotist assess the patient. And the orthotist's job is to supply them with appropriately sized and appropriate compression hosiery or stockings.
What's the clinical reasoning behind moving from bandages to hosiery? Why make that switch?
Well, compression bandages are really useful in that acute phase, especially when the swelling is significant and likely to change rapidly. They're adaptable, right? They can accommodate those changes in limb circumference as the swelling goes down with elevation and treatment.
Okay.
However, for long-term wear, especially once the patient leaves the hospital, fitted compression hosiery is generally much more practical, often more comfortable, and it can provide more consistent, graduated compression. So that transition happens when the swelling has stabilized, meaning the limb size is relatively constant. That allows the orthotist to measure accurately and fit a stocking that delivers a precise, graduated pressure profile.
And the protocol even specifies the type of hosiery they most commonly use.
Yes. It states that Class 2 below-knee cotton compression hosiery is most often requested. Let's just break that down quickly. Class 2 refers to the level of compression pressure exerted, usually measured at the ankle. Typically, that's in the range of 23 to 32 millimeters of mercury. This is a therapeutic level of pressure generally recommended for managing symptoms and reducing the risk of post-thrombotic syndrome after a DVT.
And below knee.
Below knee usually means the stocking extends just below the knee. This is often sufficient because the popliteal vein behind the knee is usually the most proximal point that needs that peripheral compression support. And cotton obviously refers to the material, may be chosen for comfort, breathability, or perhaps absorbency reasons.
And just as important as what is requested, there's an explicit exclusion for a different type of stocking.
Yes, the protocol makes this very, very clear. TED or anti-embolic hosiery is never requested.
Why the absolute ban on TED hose in a DVT treatment protocol? What's the difference?
Okay, so TED hose, that stands for thromboembolic deterrent hose. They are typically much lower compression stockings, often in the range of class 1 or even less, maybe 8-15 millimillimeter Hg or 15-20 millimillimeter Hg pressure. They are primarily designed for prophylaxis.
Prevention, right?
Exactly. For preventing DVT formation in patients who are at risk, often patients who are immobile after surgery, for example, they're generally not considered adequate for managing an established DVT. Therapeutic compression for treating DVT symptoms and trying to prevent post-thrombotic syndrome requires higher pressures, usually class 2 or sometimes even higher. And importantly, a specific graduated pressure profile where the pressure is highest at the ankle and gradually decreases as you go up the leg.
Okay.
Using TED hose instead of proper therapeutic hosiery would simply provide insufficient pressure to effectively manage the edema or support the venous system in a limb with an acute or subacute clot. So this explicit instruction really emphasizes that crucial distinction between prophylactic compression and therapeutic compression and the requirement for higher pressure, graduated hosiery for DVT treatment in this particular practice.
Right. Finally, Section 8 covers the discharge arrangements. It outlines the steps taken to get the patient ready to leave the hospital safely.
Yeah, this section really functions as a kind of checklist, doesn't it? To ensure a successful discharge, it starts by emphasizing, make sure the patient has received their compression hosiery.
Reinforcing its importance again.
Absolutely. It underscores just how important that hosiery is for ongoing outpatient management after the acute phase has settled and the initial swelling has gone down. The patient needs to physically leave the hospital with this crucial piece of their therapy already in hand.
And for those patients being discharged on warfarin, there's that specific requirement involving Lancet Laboratories again.
Yes, confirming that these patients have actually received counseling from Lancet Laboratories. This links right back to that earlier point about the lab's designated role in patient education for warfarin management. It's a vital checkpoint at discharge, just to make sure the patient understands how to take the medication safely, what the dietary considerations are, the warning signs to look out for, and the absolute importance of sticking to their follow-up INR testing schedule. Effective education is just key to preventing complications and ensuring patients are compliant and therapeutic on warfarin.
The protocol also details what Dr. Weir himself will provide to the patient at discharge.
Right. It says Dr. Weir will provide a discharge protocol, which implies, a tailored set of written instructions for the patient to follow once they get home, covering things like activity, managing symptoms, when to seek help.
Okay.
He will also provide a prescription for the patient's discharge medications. It specifically mentions anticoagulants, reiterating warfarin or rivaroxaban, those two main options that were highlighted throughout the protocol, and also pain medication. This just ensures that continuity of their pharmacological therapy continues seamlessly after discharge.
And for those going home on warfarin, that follow-up system with the lab is formally locked in.
Exactly. The protocol states he will provide a referral letter to Lancet Laboratories specifically for INR and dosage management if the patient is discharged on warfarin. This formalizes that outpatient monitoring loop. It makes sure the patient knows exactly where to go for their regular INR checks, and it ensures the lab is authorized to communicate results and handle dosage adjustments, presumably based on Dr. Weir's standing protocols or maybe direct instructions. It really maintains that integrated care model right through to the outpatient setting.
The document then concludes by just referencing other relevant protocols within their system.
Yeah, it states, please also refer to the general admission protocol and blood pressure monitoring protocol. This just puts the DVT protocol into context, doesn't it? It's one specific piece within a larger set of hospital or practice guidelines. It means that staff using this DVT-specific document must also be aware of and adhere to the overarching general admission procedures and any specific protocols they have for monitoring and managing blood pressure. It recognizes that a patient with DVT still requires all the standard aspects of hospital care beyond just managing their specific thrombotic issue.
Wow. Okay, that was a truly granular exploration of this specific DVT admission protocol. We really went step by step, didn't we?
Yeah.
From that immediate priority of patient identity, understanding the rationale behind those redundant checks, through the specific blood tests requested, like UK, Hematocrit, and their clinical relevance for anticoagulant management, including that less common one, Myoglobin, and speculating on what its presence might imply in this context.
Right. And we dissected that controlled approach to imaging requests, understanding why not all imaging is routine here, how it's physician-driven.
Then we spent a good chunk of time on that really nuanced medication section, covering Klexane dosing, the detailed warfarin management, including that critical transition point based on the INR result, and the lab's interesting role in education and follow-up.
And rivaroxaban, too, the DOAC option, and importantly, its absolute contraindication with Klexane, plus the general rule and the exceptions for using antiplatelets alongside anticoagulants.
And the pain management strategy,
crucially highlighting that absolute exclusion of NSIs because of the bleeding risk.
We also dove into the patient management section, understanding the why behind limb elevation and the specific positioning, the potential reasons for using routine oxygen, that phased approach they take to vital sign monitoring frequency, and those critical restrictions on using the affected limb for BP or venipuncture to avoid trauma.
Yeah, and stressing the importance of recognizing red flags like chest pain, thinking immediately about potential pulmonary embolism.
And we explored how thinking around patient activity in DVT has evolved, seeing how this protocol kind of balances an initial, maybe slightly cautious bed rest period with then encouraging ambulation, but specifically after compression is applied, understanding that interplay between mobility and external support.
We detailed the compression strategy itself, too, from the prerequisites of checking arterial flow first, to the reference to that specific African bandage technique, the transition later on to Class 2 below-knee compression hosiery, and that very explicit exclusion of TED hose, really understanding the difference between prophylactic and therapeutic compression.
Exactly. And finally, we covered that discharge planning checklist, emphasizing getting the compression hosiery sorted, ensuring warfarin counseling happens via the lab, and the physician providing those discharge instructions, medication scripts, and the formal referrals for ongoing monitoring, trying to ensure a really seamless transition to outpatient care.
It's clear this protocol provides a highly structured, almost algorithmic framework, doesn't it? It really maps out a clear path for managing DVT patients from the moment they arrive. For you, the specialist clinician listening, this offers a really deep look into one specific, very organized approach.
It certainly standardizes the process, it embeds multiple safety checks along the way, and it tries to integrate all those different aspects of care from labs and imaging to meds, physical therapy, compression, and discharge planning into one coherent workflow.
So here's something to consider. This detailed protocol provides that rigid structure, that how-to guide for a pretty well-defined clinical scenario. Yet, as we all know, every DVT patient is unique. They come with their own comorbidities, they respond differently to treatment, they've again social circumstances. As a specialist clinician working within such a protocol, where do you see that balance? The balance between sticking strictly to this kind of structured approach to ensure safety and consistency versus the necessary application of your own clinical judgment to really individualize care for that specific patient in front of you.
That's the key question, isn't it?
How does a protocol like this serve as a powerful baseline, a foundation, and at what points do you, the expert, need to integrate your broader knowledge, maybe the latest evidence that's come out since the protocol was written, or just the patient-specific presentation, to perhaps tailor or even deviate slightly from the approach that's outlined here? What are the real advantages of having this level of prescriptive detail in a protocol, and what are the potential challenges it might create when you're faced with the inevitable complexities and nuances of real-world patients?